All right, so moving on to the neutrophil. So starting off here, neutrophils are going to kind of go through a long process in terms of their formation. Now, we're not going to go through every single step, but something to be familiar with. We have the metamyelocyte, which comes from the myelocyte, and eventually it goes on to form the band cell that will eventually turn into a mature neutrophil. Now, just like when we talked about reticulocytes leaving the bone marrow, going to the blood, and then eventually after a day or two forming an erythrocyte, similar process here, right? These are all going to come from the bone marrow, right? These band cells specifically are going to come from the bone marrow, and eventually they're going to go into the blood. Now, the thing here is these band cells will eventually either get activated or exposed to a pathogen potentially that will eventually lead them to forming a mature neutrophil in the blood. Okay, now these neutrophils that we have in the blood, so the neutrophils can make up, upwards of 50% of all of your white blood cells. An easy way to think about this is your white blood cell count is essentially going to go where the neutrophils go, right? So if you have really low neutrophils, your white blood cell count's probably going to be low. So you'll sometimes see the term neutropenia used in conjunction with a low white blood cell count. Now, neutropenia specifically is referring to the neutrophils, right? And a lot of times these terms are used in conjunction because for the white blood cell count to become low, you have to knock down your neutrophils, okay? So that's why these terms are sometimes used synonymously. So because of that, you might be saying, well, how do we know what the neutrophil count is supposed to be? Well, sometimes we'll look at the absolute neutrophil count, okay? And we're going to talk about this in more detail to come. The absolute neutrophil count, or the ANC, will tell you the number of neutrophils that you have. And we'll talk about this in more detail to come, but just giving you kind of a high-level overview of what we're talking about. Point being here, though, is that neutrophils make up a significant portion of our white blood cell. And just like when we talked about reticulocytes with red blood cells being elevated when we're in a situation of hypoxemia or in a situation where we have a lot of erythropoietin being released, we also can have a high level of band cells released into the bloodstream when we're in the setting of things like an infection, for example. Okay, so if there's a large number of band cells, right, so if my band cells go way up, that might signify that we have an infection on our hands because we're essentially trying to produce more neutrophils, right, to fight off the infection. It's very similar to what you see with red blood cells. Okay, so we'll come back to this in a second when we get to the pathology. So remember the big thing that neutrophils are doing. They're essentially going to be undergoing phagocytosis to pathogens, right? And so when we have phagocytosis that occurs in a neutrophil, eventually we form a phagosome within the neutrophil, right? So the neutrophil will eventually phagocytose some bacteria, right? If I have some bacteria here, and then it will put it into a phagosome. And that neutrophil will then try to essentially destroy the contents of that bacteria. And it's going to do that through the respiratory burst pathway, okay, which we're going to talk about in a separate video. But this involves things like the activation of NADPH oxidase. And this NADPH oxidase, remember, this is going to eventually help form superoxide. And then that superoxide can get converted by superoxide dismutase to hydrogen peroxide. And then one of the most important parts here is that hydrogen peroxide can then get converted to hypochlorous acid, and this is all done by myeloperoxidase, MPO. Okay, and so this is all going to kind of come together. But what I'm trying to say is we have a phagolysosome or phagosome, and inside of that we have a respiratory burst pathway after we phagocytose a pathogen. And like I said, we'll go through that whole pathway. I just went through it quickly here for review, but we'll go through it in greater detail in another video. So phagocytosis is one of the key things you'll see these neutrophils doing. We also have degranulation of these granules that we'll talk about in a second that can happen. We see this a lot when we talked about things like type 3 hypersensitivity reactions where the neutrophils, where they're essentially just kind of dumping these toxic substances on host tissue, right, where there's antigen antibody complexes. And finally, remember to get the neutrophils to the site of an infection, right, or site of acute inflammation, we have chemotactic agents. The big three, the high yield three that you absolutely need to remember are LTB4, right, leukotriene B4, interleukin 8, and C5a. Those are very classic for neutrophil chemotactic agents, usually in the setting of an acute inflammatory response. Now remember, neutrophils, when they get to the site of inflammation, right, they're going to have granules. Like we said, there's going to be degranulation, there's going to be phagocytosis that eventually leads to the formation of pus. So neutrophils, very classic for leading to the formation of pus, right? Now you might be saying, well, why is that important? Well, if you have an infection where you don't have pus. There's usually a defect with the neutrophils. For example, leukocyte adhesion deficiency that was discussed in the immunology section. We had leukocytes that couldn't get to the site of an infection, therefore couldn't generate pus, right? So that's where you kind of put all of this together. So an absence of pus would suggest some defect with the neutrophil or the neutrophil's ability to get to the site of an infection. First type of granules, these eosinophilic granules, are going to contain multiple substances. But if there's one thing that you absolutely want to remember that are in these granules is myeloperoxidase. And this is by far the highest yield thing, in my opinion, that you need to know about this. That's largely because myeloperoxidase makes up a considerable amount of what's in those granules. And these are going to tend to be a darker, more purple staining granule. So here you can see a neutrophil, and you can see there's a couple different granules in it. These darker granules, these are going to be more of the eosinophilic granules, and these are the granules that will be containing the MPO, right? The myeloperoxidase. And what does that myeloperoxidase do? It converts the hydrogen peroxide to hypochlorous acid. Again, we're trying to create toxic substances in the phagosome to destroy the invading pathogen. And this is assisting with that essentially. And then we also have some specific granules. And these specific granules have, multiple substances, again, all kind of working to destroy these pathogens once we create our phagosome. Okay, so we have leukocyte alkaline phosphatase, lysozyme, and lactoferrin. And we'll talk about all of these most likely in different video series, and I don't want to get too off track, but these are definitely three big ones to remember for the specific granules. And again, these are going to be more of the pink staining granules. So here's my neutrophil. Okay, so here's my neutrophil. And you'll notice too, the nucleus here, it has a couple different lobes. So it's lobular, or we can say it's segmented. It has kind of different segments to its nucleus. Okay, and so those segments and that lobular appearance is very classic for a mature neutrophil. Okay, and you might be saying, well, we also saw that there were some segments in the basophil. So how do I distinguish the neutrophil from the basophil? Remember, the basophil is going to have a much darker blue staining nuclei and granules in general. The neutrophils are going to be more kind of neutral pink staining, and then the eosinophils are going to be very dark, kind of red staining, more acidophilic. And also, you'll note there's a cell here next to the neutrophil. So this is the band cell. And the way to kind of remember the band cell, right, which essentially is the more immature form here. So the band cell kind of has a horseshoe appearance to the nuclei. Okay, so the horseshoe nuclei is very classic for a band cell, right? But when we have these discrete segments, for example, if you look at this cell, you can see there's discrete segments and lobes in this kind of neutral staining neutrophil. That makes it very classic for the mature form, right? The neutrophil. Whereas if we look at this image here, we can see more of that horseshoe appearance to the nuclei, again, staining kind of a neutral pink color. This would represent a band cell or a more immature form, as opposed to what we see here being more of a mature neutrophil. Now, like we said a moment ago, going back to these band cells, if you had a lot of band cells, in other words, a bandemia, right? Band referring to the band cell, and then emia referring to in the blood, right? A large number of band cells in the blood, that could signify potentially an infection. Now, you can also see this with things like chronic myelogenous leukemia, right? We kind of talked about that already. You can have a large elevation in your white count in the setting of chronic myelogenous leukemia, where you're just basically pumping out a bunch of immature cells. And we also said that if the white count's very elevated and the percent basophils are also very elevated, that can be a clue potentially that you might be dealing with CML. Now, this whole process is referred to as a left shift. In other words, you have a higher percentage really of band cells, particularly in the setting of a high white blood cell count. That most likely, in most situations, it's going to be referring to an infection, although it could be related to a more malignant process. Now, there's also the leukoerythroblastic reaction. Now, let's just break this word down. Now, we're going to start back here. So blastic referring to more the immature forms of white blood cells and red blood cells, right? So if we have a left shift with a very high number of reticulocytes, or potentially some other form of red blood cell, right? It could be erythroblasts, could be another form of white blood cell, could be a metamyelocyte, right? In other words, we have immature forms of these cells being released into the blood. And this is also a significant finding. It could be related to things like metastasis. And like I said, we're going to talk about this as we go through this video series. And of course, you can also have quantitative defects, right? You can have really high levels of neutrophils. You can have really low levels of neutrophils. Whatever happens in the white blood cell count, very likely it's going to affect the neutrophils, right? Because that's where the majority of the white blood cells are made up of neutrophils. So if you see a neutrophilia or a leukocytosis, right, the first thing you always want to look for, in a board question or in real life, is this patient on glucocorticoids? Okay, so that's important because remember, these can kind of cause demargination of the white blood cells of the neutrophils and cause the white count to be elevated. Okay, doesn't necessarily always mean we're talking about an infection. Okay, but also we said infection, very classic, particularly if we have a bandemia, if we have a left shift, because that tells us not only is the white count elevated, but we know that the bone marrow is responding to that by increasing the amount of white blood cells being released. So a bandemia in the setting of neutrophilia is more suggestive of an infection than just a neutrophilia or leukocytosis on its own. Now, with neutropenia, this can be from a lot of different things. This can be from chemotherapy. Certain medications can cause you to have this myelofibrosis if we have multiple cell lines involved. And like I said, we're going to talk about a lot of this. The last thing I want to hit on in the pathology section here, and this is particularly high yield, is hypersegmentation. So what are we talking about with that? So you notice when we're looking at a lot of these neutrophils here, we're looking, they have a few different lobes. Usually, neutrophils will have around 3 to 5 kind of distinct lobes. Okay, usually they'll have around 3 to 5. Okay, so we can see here we have 1, kind of 2, maybe 4 here, 1, 2, 3, right? So they're all kind of in that range. Now, when you have more than 5, okay, so greater than 5 lobes, now you start to call this hypersegmentation. When does that happen? Classically, that's going to happen with vitamin B9 and B12 deficiency. We're going to go into more detail on this when we talk about the anemia section. That's very classic and very high yield to remember. So when you see these smears, right, always be on the lookout for, neutrophils that have 6 or 7 segments in the setting of an anemia, for example. All right, finally, the last thing on here, just some pharmacology to be familiar with. So we have filgrastim, which is going to be synthetic granulocyte colony stimulating factor. Remember, these are granulocytes, right? They have granules, and mast cells actually technically are also granulocytes. But again, we're talking about something that's going to stimulate the granulocytes. Okay, so filgrastim is kind of similar in some ways to the erythropoietin of red blood cells, right? It's going to stimulate the bone marrow to produce granulocytes. And a lot of times you'll see this given if a patient's on chemotherapy or had radiation therapy, and now they either have, myelofibrosis or the effects of chemotherapy has caused them to have a really low neutropenia, right? They're going to have a really low absolute neutrophil count. So we want to stimulate the neutrophils. And so we can do that using granulocyte colony stimulating factor. Now, the only difference here between the medication below it is that this also has monocyte stimulating in it, right? So we'll also be stimulating monocytes, which can eventually form macrophages. Okay, so just a very slight difference, but a lot of times you have to be able to distinguish these kind of very minor differences in board questions.